So, I'm a psychologist. What am I doing here? I'm not going to teach you anything about IVF, none whatsoever. I am, however, going to tell you, I'm going to start with what I'm doing with regards to medical decision making. And I do quite a lot of things in that field. So the title of my talk is, You're Talking to Me, you know, like Robert De Niro, except not exactly the same thing. And I'm going to be talking about how to ensure patient comprehension, mainly comprehension, and then motivation and personalization, because my claim is, if you don't understand something, you're not going to be motivated. And I'm going to start by introducing myself academically. Zev already did that. Introducing my industry experience. And then I want to tell you about a morning I spent in 2004 at the Hadassah Medical Center. I was invited to teach the psychological principles of decision-making to genetic counselors. I said, okay, but because I had children before I knew any of you guys and before I met genetic counselors, I said, I can't teach genetic counselors unless I know what their job looks like. So I came and I sat in on consultations. And the experience was very difficult because I saw a great professional, smart, knowledgeable, well-intentioned, equipped with a lot of information, standing here. I saw a patient, actually with her husband and her baby, and the translator, because the patient was deaf, listening, obviously very motivated, wanting to receive all that information. And then I saw as if there was a gap in the floor, and 90% of the information from the professional to the patient just fell through the gap. And that really sparked my interest, and from then on I've been very committed to the idea of medical decision-making and to trying to understand how to facilitate that, how to help professionals enable understanding with patients, and how to help patients understand a little bit more. So the roadmap to the talk is, how do we make patients do the right thing? And I'm going to claim that, yes, I'll be talking a lot about comprehension, but comprehension is not a goal in and of itself. It's the path to better adherence and to better patient behavior. I'm going to be talking about this in terms of the 4 no-nos, as I like to call them, the 4 things you should not be doing. And I think Avi is a champion at avoiding all these no-nos. So I'm really glad to be speaking immediately after him. We'll talk a little bit about motivation and a little bit about personalization. But we'll start with this question, with the patient who doesn't look like he really knows what's going on. Who should understand medical information? Are there any doctors here? Clearly. So you should understand medical information. Should the patients understand that? Well, it depends on the model you work with. If you work with a very paternalistic approach, you would say, I'm the doctor, I'll tell you what to do, and you'll do it, and don't ask me questions because you have no say in the process. If you come from a shared decision-making perspective, you will want the patient to participate. Now, that doesn't mean she gets to say what the dosage is or any other of those medical decisions per se, but she will have some form of input into the process. This isn't just about because it's important. I mean, the BMJ published a paper from my collaborators in shared decision-making, the Salzburg Address almost, the Salzburg Statement on shared decision-making, and in there they say nothing about me without me. That's great. But do you agree? Well, you don't have to agree. You have to ask, is this evidence-based? And the answer is yes, it is evidence-based. When patients are more empowered, they do things differently. It's not about being nice to the patient, it's about better outcomes. And we're talking about diabetes, hypertension, heart failure. We're talking about multiple conditions where having the patient participate in the decision-making process actually makes a difference. Additional results that we see here, patients, and we're talking about procedures like knee replacement, hip surgery, etc., are less likely to undergo medical procedures, often at no disadvantage to their health. They're more likely to decline interventions, and as I said, and they're more likely to adhere to their medical regimes. So having the patient participate in the process is actually important, not just because we think it's nice, but because it actually assists the medical outcomes. Shared decision-making has many tenets, but I want to point out 2 of them. And they seem like a no-brainer. Okay, the first one, both parties take steps to participate in the process. You could say, duh, yeah, of course, right? But we're going to see it's not that trivial in a minute. And information sharing is a prerequisite. One more question, and then I'll start bombarding you with information. Who should make medical decisions? A fourth of the patients say, only my doctor. Half say, me and my doctor. And a quarter say, well, just myself. And this is kind of old data. I don't know what it would look like right now. I wonder about the distribution. The fact of the matter is, the more you inform patients, even a little bit, the more equipped they feel to participate in the decision-making process. And like I said, it doesn't mean that they're going to change the protocol or decide when to inject or what type of medication they need to use. It just means that they feel they are taking part in the decision-making process, and when they're informed, they're likely to do that. So, do patients get it? An important question. I would like to ask another question, and that is, are they supposed to? What message are we sending to the patients, and are we really inviting them to the process? So, I'll be talking about 4 barriers to patient comprehension. I like to call them the no-nos, and the first no-no is talking above the patient's head. A simple example from a commercial website, DNA Direct. They are not doing pro bono work. They are trying to sell these DNA direct-to-consumer genetic kits. When you look at this, and try to look at this not from professional eyes, try to look at it and count the words that are very long. How many are there? You know, more than 1, more than 5, more than 10. There are a lot of long professional words. The graphics indicate this is complicated. Even the founder of the company looks like she's not really getting it for sure. So when I'm a patient, when I'm a consumer, I'm looking at this and it's telling me, Talya, you're not smart enough. You're not going to get it. So what's the message here? Is there true information sharing, or is there information sharing but also telling, guess what? This is not for you. Another example from the field of depression, and I did not make this up. Please read the line that's marked in red. Maybe it's true. It could be very honest to say that you don't know how the medicine works. But by saying that, by not giving any real explanation, you're really telling the patient, take this because I tell you so, and I know best. Another example. A woman was prescribed beta blockers. She asked the doctor, what are those? He said, they're good for your heart. Asked the nurse, they're good for your heart. She gets them. She goes home. She looks at them and she thinks, well, it's a beta blocker. I'm blocking something in my body. Is that a good idea? I'm not really sure. Well, I don't know. I'm not going to take this medication. Why? Lack of comprehension. So you can say, this is self-explanatory. Everybody understands that. Everybody knows. Everybody can Google it. But the truth of the matter is, you can't always find credible information, and you have 90 million Americans of low health literacy. Their reading level is that of a sixth grader or less. So we can't really count on people understanding what we tell them. I want to show you results from a study I did at Princeton University. And I always say it's at Princeton, not just because I went there, but because Princeton University students are very smart. You can't say these students don't get it because they're stupid. They are not stupid. You can't say they don't get it because they're women, they're hormonal, they're pregnant, they're anxious. None of the above. These are young students. They're not pregnant. They don't plan on getting pregnant. They're uber smart, and they're high achievers. So when you give them a task, they want to get it. And the task here was read a letter that was written to an expectant mother describing her triple serum screening results and tell us what the risk of this woman having a child is with Down syndrome. We presented the information in 3 formats, and this really feeds off the work of Gerhard Gigerenzer, who presented here yesterday. The first is probabilistic format, and that's the standard format. This is how the Hadassah Medical Center sends information to women. And that's very clear, or should I say clear, to everyone because it's really standard. The probability of giving birth to a baby with Down syndrome for a woman with normal results and 1 over 724. That's the base rate. And then there is the probability of having such a baby for a woman with your results. That's 1 over 181. The frequentist presentation doesn't talk about numbers so much. It talks about fetuses, babies. You can envision that. You can think of a room with 181 babies, and the one in the corner, in the middle, of wherever you want to put it, is the one with the Down syndrome. So it's not numbers anymore. It's fetuses. It's babies. Does it make a difference? We shall soon find out. The last presentation format is the visual one, which really translates the frequentist format. This is the base rate. You have a lot of white circles and one black one with the Down syndrome. And then it's followed by this woman's risk, less black circles and one white one denoting the baby with Down syndrome. Do you think this makes a difference? Who thinks it's going to make a difference in comprehension? It's the same information, basically. Who thinks it's going to make a difference? Okay, so I have some believers here, and that's great. And as you can see, understanding, just being able to answer a simple question, what is the risk of this woman to have a baby with Down syndrome with the probabilistic presentation format, which is really standard issue, is 33% in this very smart, savvy, non-anxious population. That's, I would say, a tad, if not more than a tad, disturbing. We have the visual presentation, which is better, and the frequentist presentation, which is substantially better. It's almost at 70%. Now, 70% is the best that we've gotten to, and that in and of itself is, again, disturbing. People don't always understand what we tell them, even if it's simple, even if they're smart, even if they're motivated. Okay? I want to move on to another dependent measure, and that is not comprehension. That is the risk high? Is it low? Is it medium? Why are we asking this? Because not all decisions are cognitive. Some of them are emotional, and I'm betting that a lot of the IVF-related decisions are emotional. So we asked, how would you rate the risk here? There's no right or wrong answer, but we do see that with the probabilistic format, the red line, which denotes low, is substantially lower than it is for frequentist and visual presentation format. So if you receive the information in the frequentist format or the visual format, you're much more likely to think that your risk is low than if you received it in the probabilistic format. Now, this is very bad news to genetic counselors. They always want to beat me up when I say that, because what it means is that there is no objective way to present information. You present information a certain way, and it's going to influence the way it is comprehended and the way it affects you emotionally. Now, you can say, well, let's just ask the patients. Do you understand the information? Maybe they have an intuition. And the truth is, they don't have an intuition, because we asked, how clear is this information? How clear do you think it would be for a woman to decide whether it's good or bad when she receives the letter? And participants who received the information in the probabilistic format thought it equally clear as those with the frequentist format. But you can see that the results, the objective results, were very, very different. I'll gloss over very quickly information from the National Cancer Institute. This is about BRCA 1 and 2 testing for breast cancer. And what are the odds of the lifetime risk prevalence of developing breast cancer given these genes. We ran this study with older women, women over 45, for whom this is really relevant. It's more relevant than it is for students. Half of them chose the correct interpretation, which of course means that half of them chose the wrong interpretation, and the options are presented here. The bold one is the correct one, number 2. The wrong one is number 4, thinking that if you have the gene, it elevates your chances of developing breast cancer by 36 to 85%. No, it elevates them substantially more, but half of them get it wrong. Wait, I want to go back for a second. When we try to understand what is driving this, we examine a variable of numeracy, people's ability to juggle numbers in their heads. It's correlated with intelligence. And we see that the ones who are less numerate, who are less intelligent and potentially less educated, are much more likely to choose the wrong interpretation. They are also much more likely to be willing to pay more for testing. And I will get there in a minute. So the first point was, do not talk above patients' heads. And evidently, even information which we think is very simple sometimes is above patients' heads. The second no-no, the second potential barrier, and again, it's crucial, I think, with IVF, is to manage expectations. What does that mean? Clearly, when a woman comes in for consultation, you don't tell her, I guarantee you will leave this room pregnant within a month, okay? This is probably not something you tell women. But what are they hearing? What are they expecting? And we ask this question for the same women about the BRCA 1 and 2 test. We ask them, what are your expectations of the test? What is important to you with this test? The thing that was most important was that the test would give me information about my BRCA 1 and 2 status. It's very important for most people, and that's great. That's what tests do. Then we started getting nasty with our trick questions. And we asked, how important is it for you that the test will tell you with certainty whether you will develop breast cancer? Can a test do that? No. It can only tell you whether or not you have the gene. Granted, the prevalence of developing breast cancer with the gene is high, but it's not certain. So a third of our participants said, this is very important to me. I want to take this test because it will tell me with certainty whether I will develop breast cancer. Another trick question. How important is it for you that the test will tell you what to do if you have breast cancer? Can a test do that? Guess what? No test can tell you, do a lumpectomy, do a mastectomy, do watchful waiting. Who can say that? Your doctor can advise you and you can decide, but a test will not tell you that. So again, about a third said this is very important to me. These were their expectations. And we did give them an option of saying the test can't do that. Half of our participants said the test can't do that. Come on, there's no certainty, there's no advice on treatment. But a third of our participants, again, those of lower numeracy, were the ones who said this is very important to me. They were willing to pay, on average, $250 for this test. Our participants of high numeracy were willing to pay less than $100. There's a huge gap. I didn't bring the graph, but seriously, think 100, 250. That's how big the gap is. Because of these expectations and because people of lower numeracy find it much harder to cope with numbers. So the second no-no is manage expectations, because otherwise the patient will come back to you and say, so now tell me what to do, and now I have the gene and I know I'm going to develop breast cancer, and you have to undo all these expectations. The third no-no is the no-no of giving too much information. Why is that a bad thing, to give too much information? Because when you give a lot of information, it's very hard to tell which of it the patient will actually retain, what they will go home with. And I want to give an example, which you can think is very funny, or you can think is very sad, or maybe tragic comic, from a session where a patient, not even a patient, a relative of an Alzheimer's disease patient, was given her risk information. So she comes in for consultation, is a 59-year-old woman, and the first piece of news she receives is the genetic test came back, and you have 2 copies of the ApoE gene. One of them is the ApoE3, which is the benign one. One of them is the ApoE4. That's the bad one. That's associated with alleviated risk, elevated risk. So far, so good, right? And then they go on. That means your risk of developing Alzheimer's disease, your lifetime risk, is 52%. Your risk before we tested you, before the genetic testing, just because we know your father has Alzheimer's disease, is 29%. And that compares with about 10 to 15% chance in the population. The patient then asks, what would happen if I had 2 copies of the bad gene mutation of the ApoE4? And the answer is, well, it's around 60% chance of developing Alzheimer's. And then the geneticist says, but don't worry, because you've already lived through 7% of your risk. What is her risk of developing Alzheimer's disease? No, Milton says no. Do you think it might be too confusing? Do you think maybe if we really want her to know what her risk, her remaining risk, not from when she was born, from now when she's 59 until the age of 85, if we want to know what her risk is, maybe we should tell her. Okay, it's never said here. She's never told. It's 45%. She's given a bunch of other numbers, but she is not given the one number that she needs to take home with her. So, is it good to give information? Yes. Is it a great idea to give too much information and then not make sure that the patient takes home the one crystal clear piece of information that she needs? I don't think that's such a great idea. This ties in with the fourth no, and that is sending them home with nothing. When all they're left with is the memory of what you told them, and they may have retained all of it perfectly, but how likely is that to happen? Then God knows what happens when they go home. So what Avi presented from Shaarei Tzedek, their system, is great because it's printable, it's there, they can go back, they can revisit it. They don't have to rely on their memory, because when they do, basically, honestly, I don't want to say it's a mess, definitively, but it can be a mess, and we don't want that to happen. So all of these are great barriers to patient comprehension, and patient comprehension, without it, you don't really have great adherence, and you can't expect people to follow up protocols. I'm going to run through the rest of it relatively quickly. A number of suggestions, probably not very likely to happen here, but one idea is make it intuitive and find out what your patients don't know. It's an example that I like to give. It attests to my ignorance, really. This is the Empire Hotel in New York. It's really nice. They have a great lobby. They have rooms the size of this podium, I think, is the size of the room pretty much. And the showers are, of course, alongside with the room. And when you get in the shower, it's very hard turning on the hot water. I'm not sure why, but I've stayed there a number of times and it's hard. And I've heard people go to the receptionist at the lobby and saying, I couldn't get on the hot water, I took a shower in the sink. I doubt that the managers of the hotel planned it like that, okay? It saves water, but it sort of hinders your reputation. Do they even know that this is a problem? I'm not sure. I'm not sure they understand what an embarrassment and what an inconvenience this is to their clients. So maybe something like this is going on in your clinic. I hope not. But if it is, would you be able to know about this? Would you have the information? Would you be able to fix it? I've spoken a lot about knowledge. Knowledge isn't everything. Ask Penelope Cruz. Not because beauty is a main thing. That's not a topic of our conversation today, but because she knows smoking is bad for her and still she smokes. Why? Because even when we know we need to do some things, we're not always motivated. So the 4 M's are motivation, motivation, motivation. It's key. I think with IVF, you're almost spoiled in the sense that you have highly motivated patients. But still, when you want people to be motivated, over time and protocols that are not always so much fun to follow, you want to make sure that doing the right thing feels good, is rewarding immediately, because injecting yourself can't be that much fun, right? So how do we make sure that doing the right thing feels good? We assign meaning. We motivate by assigning meaning. We don't just give people numbers. We give them meaning. This is good, this is bad, you're doing great. And what we see here is a system where you can mark your own glucose level. And it says hello from Glucose Buddy. It's a really nice glucose app. If anyone's interested, I have absolutely no commercial investment in it. and it tells you what your blood sugar level is. It's 120. Is that good or bad? Better than yesterday, because yesterday was 130? I don't know. Does the patient know? Probably not. So if you're not telling the patient where they are, good, bad, improving, what's the meaning, they may or may not continue to use this app over time because it doesn't tell them where they stand. We're emotional creatures. We need to know something that is beyond a number. I love this example. It's from a company called Hilarium. They monitor health and they try to promote health and prevent chronic disease. And they approached me a couple of years ago and showed me these. They had 2 more clocks. And I said, that's great. And that was clearly developed by engineers. And they didn't like this because engineers are wonderful at creating systems, but they're not always wonderful at helping assign meaning. Where do I stand? I'm a person, good, bad, at risk, really worried, should go to the ER, I'm dying. Where do I stand? And then they added this little button here that says, overall, this is your heart disease risk. It's not very high. You're still in the green zone, but you're approaching the orange zone. And they say, well done. Hey, well done. This is good. This is nice. This is motivating. If it's motivating, I will continue. If it's not, I may drop off. Okay. Putting a picture of a cow is a little bit disconcerting. Why did I put it up here? Because I heard over the radio a study indicating that cows who have a name, this is for real, cows who have a name, like Daisy or whatever, as opposed to cows who just have a number, produce 4% more milk. I think it's amazing. And I think it means that, I don't want to say cows like to be treated as people, because I don't know they have this thought process, but they have feelings too, and people clearly have feelings. So when we speak to the person, not as patient number, but as a person, she's more likely to adhere and to be motivated. We see this with HIV, and people who have HIV know that they should be very, very adherent, or they might as well not take the medication. HIV patients who answer one question, my doctor knows me as a person, are more likely to adhere to the treatment. So this is crucial. This is critical. You can be the best physician on earth, but if the patient feels that she is number 1455 and not Sarah or Amanda or someone who likes yoga or golf or whatever, maybe she's less likely to adhere. The cost of personalizing can be minor, but the benefit is huge. And I want to show a nice study from the University of Michigan where they used personalization in their communication in a smoking cessation intervention. Very difficult to make people quit smoking. What they did is they tailored it. You're a man, you're going to see a man. You're going to hear about his age. A highly tailored intervention is when you're a woman and you see a woman and she's talking about, as a mother of 3 children, hey, now I'm listening because I have 3 children too. And if she does too and she quits smoking, then I relate to her more than I would relate to a man, or more than I would relate to her if I knew nothing about her or heard that she was 25 and going out dancing every night. So personalization helps motivation. The last thing I want to show you is an example from a study I did with the FDA warning on cough and cold medication. The FDA sent out the warning to parents, don't use this medication in children under 2. What did parents do? Ignore the FDA warning, of course. Why do they do that? And who does that? So we found out that experienced parents who have already had children under the age of 2, the kids are older now, and they gave the medication to children, and nothing happened. They're more likely to ignore the warning. So experience creates an immunity to the information. Of the new parents, about 53% adhere to the warning. Of the experienced parents, far fewer. We had to dig into the information in order to find out, in order to see this difference, in order to distinguish the experienced parents from the new ones, and to find out what would be a good message for them. I emailed the FDA. I was very surprised. They actually emailed back. I asked, did you segment the message? The answer was no, we just sent out the same thing to everyone. How effective is that? Probably not incredibly. So I'm not suggesting you do major heavy analytics with your data. I'm just saying try and see if you can find trends that are meaningful in the data you already have, and perhaps tailor your messages to patients accordingly. Okay. So in conclusion, I hope I convinced you that behavioral insights can make a difference, that you should avoid the 4 no-no barriers to patient comprehension, which are talking above patients' heads, not managing expectations, giving too much information, and sending patients home with nothing, with no written communication. I hope I convinced you that it's important to embed motivation, even though, like I said, you're probably a very, very spoiled practice in terms of adherence, and that personalization can go a long way. And if you can use analytics to find out what your patients really want and what the messages are that would resonate the most with them, it's a good idea to do that. I'm looking forward to hearing from you, to hearing your comments and your questions, and to keeping in touch. And thank you, everyone, for coming to this terrific event.